has there been new research in the past few years, or is it something that was once discovered or thought of and nothing has changed since then on the thinking on it?
No, there's been a lot of research, and it's sort of in three general areas. One is neuropsychological testing. You're all familiar with what that is. This is not brain imaging, which finds lots of different cognitive deficits associated with poor insight. I'm going to use that term broadly, or unawareness of illness. Over the last 10 years, there's been a great deal of research using different imaging techniques, so structural imaging, finding, for example, less gray matter in the frontal lobes, and functional imaging, how the brain is working, finding hypofrontality and other we could spend. I was opening this up to look at the review. I have a new review in here, and the last article that was reviewed in this edition was just published 3 months ago. So people are still looking at this. They're still trying to detail the pattern of brain dysfunction. The brain is very complex. It's not simply the frontal lobes. It looks like verbal memory is also, and memory, not surprisingly, is a part of the picture.
And DSM-5 is now in process of being updated. Do you have a role in that process with respect to anosognosia?
I don't have a direct role, no. I was asked, I don't know how much you all know about the DSM process and how people get involved in it or not, but I have a role certainly as a scientist who's written in the area. Will Carpenter, who is the chair of the schizophrenia section, asked me to guest edit a special edition of Schizophrenia Bulletin, which is the NIMH's journal on schizophrenia. And so we have a special edition just on insight. In that edition, we're going to have an update on brain imaging findings, neuropsych findings, techniques that we can use to engage people in treatment, like motivational interviewing and like techniques. We are having a public policy article as well. So given the science, how should public policy change with respect to persons with serious mental illness who have anosognosia for the mental illness? And then I'm working on an article which is to propose a subtype, schizophrenia with or without anosognosia. And I'm very eager to do that because I would like all our psychiatrists, psychologists, social workers, nurses to be obligated to look at this question. When this person walks out of my office or leaves the hospital, are they likely to throw their medicine away? Are they likely to not fill a prescription? Because from their point of view, it's common sense. I don't need this medicine. My brother used to tell me I'd be crazy to take this medicine. And I used to say, no, you're crazy. He'd tell me you're crazy. We go back and forth. But in fact, he's right. And he was right. So if it's in the DSM, where you have to determine, does the person have insight or not, anosognosia or not, it changes your treatment plan. It changes even the kinds of medications you would propose giving. And there's a lot of literature on long-acting treatments, long-acting injectable medications, for example. Grossly underutilized here, used all the time in Europe. It's amazing the differences between our two countries. And they don't have the kind of problems that we have with adherence, with engagement and treatment. We have between 50 and 70% of persons just talking about schizophrenia who do not take medication. And I understand why they don't, because of this symptom.
We're going to deal a lot more with treatments and modalities in the course of this. But getting back to anosognosia, what it is, who believes it, do you find that it is well accepted in the community, in the medical community?
When doctors look at the research, or page 304 of the DSM-4-TR, the acceptance goes up. Yes, it's well accepted. It makes sense. I see when I give talks to colleagues, light bulbs go off. I don't think I've ever had a major debate, and I invite debate all the time with colleagues. But there is still a resistance to the idea simply because we were all trained that this was denial. I don't know if there's any residents in the room. Anybody here a psychiatric resident? Have you been trained that this is denial when you see a patient with schizophrenia?
No, I'm a psychiatric nurse, but I attest that it's in the process of changing.
It's in the process of changing.
I'm doing my dissertation on insight.
Okay. She's doing her dissertation on insight, for those of you who couldn't hear. But that's my experience. And there's no resistance when they hear the message, when they hear the data. But there's still, it's not widely known. I wouldn't say it's not widely accepted. I think it's not widely known yet.
I would just say I went to UCSF in Stanford in primary care, and we see a lot of mental illness. We do get a lot of behavioral therapy and stuff. And I've been shocked being on the panel. We didn't hear that at all, because every day we're in the ER, we're seeing people with these illnesses. So it sounds like I had no, in fact, I didn't know that was the training beforehand. That any of my peers, there would not be one that would question it.
So they would say it is anosognosia.
Oh yeah, they don't know how to. I can't even say it.
I can leave now. My work is done. I've been talking about this for 15 years. I've been talking about this for 15 years, and I was here at a TAC workshop in 1999. The only reason I'm Not Sick exists is because of that workshop, and the room was filled just like this, because this is a real serious problem that we're dealing with. And a couple came up and said, "You got to write something for the general public." And every time I give a talk, who knows the term anosognosia? I'd see one hand go up. 2, 3. I've been doing this for 10 years now, and now I see half the room. So that's why I don't think it's widely accepted yet, or known. I'm delighted to hear that. It's amazing. Well, TAC has a lot to do with this.
We're talking about anosognosia in the context of severe mental illness. Does it apply in other cases of medical infirmities?
It's a really interesting question. My opinion is yes. Do I have data that I can point to? No. But I will say this. There's a scale my colleagues and I developed, David Strauss and I, back in the late 80s. It's a scale to assess unawareness of mental disorder. And that scale has been used in studies of people with eating disorders, obsessive-compulsive disorder, which we do have, by the way, subtypes of with or without insight, right, for OCD, and addictions. So I believe any brain disorder that involves deficits in frontal or executive function is likely to be vulnerable to this symptom. Yes. But do we have the kind of data we have in schizophrenia and bipolar disorder? Not yet.
Okay.
What about physical?
What about physical ailments? For example, there occasionally you'll hear folks say, point to a stroke victim, and the idea being, tell it, move your left arm if the person is isn't aware.
Well, absolutely.
We hear that.
This has been described probably for 2,000 years. Seneca wrote about a woman with anosognosia for hemianopia. She didn't understand that she was blind, and she would say to him, "Would you keep the house dark?" And I've evaluated a patient like that. Imagine not knowing that you're blind and trying to understand what people are saying you are, and becoming suspicious and coming up with explanations. So certainly in neurological disorders, but also in cardiac disease. There's some people who have contacted me, and they think denial of medical illness may involve some reduced blood flow into the frontal lobes of the brain. There are many people who've had diagnoses of cardiac disease who appear to be in complete denial of it and don't get help. So those are theories that are out there. People are looking at it.
This is a good segue as we're talking about anosognosia as it pertains to individuals. And John Sandler